Hello and welcome back to our YouTube channel called the Rheuma Talks. So today we will be discussing about the most common drug used in rheumatology, that is steroids. So let us understand what are the myths and what are the facts regarding use of steroids in rheumatology. So if you see, when was steroid discovered? Steroid was discovered initially in the 1930s by a biochemist and by a rheumatologist. So if you know the name of these two scientists, so please let us know below in the comment section. So this compound was initially named as compound E in the 1930s. So later on, many synthetic forms of steroids became discovered and used for various indications in rheumatology. So nobody knows better than a rheumatologist about the dose and usage of steroids for the right indications for various diseases. Okay, so is steroids harmful or beneficial for the human body? So for this we must understand that every human being produces steroids in their body. Okay, any human being who is alive produces some amount of steroid in their own body on a daily basis, and it is follows a circadian rhythm. That is, the maximum endogenously produced steroid is maximum in the morning, and later on towards the evening the steroid production in your body decreases. So how much is this steroid being produced by a human body? Well, it is almost 10 milligram of cortisol that is being produced in your body, mainly the adrenal glands. Okay, adrenal glands are basically a small glands which is located above your kidneys in the abdomen. So this normally produces around 10 mg of cortisol in your body. Okay, so but this level can rise to 3 times to 6 times the production capacity in terms of stress or any acute conditions like a stress, trauma or anything. Endogenously your body will increase the production of steroids by 3 to 6 times. Next is, when do steroid usage becomes harmful? So steroid usage becomes harmful when it is used for an indication which is not required, okay, or it is used in a high dose which is not required to be used at such a high dose for a particular condition, or if patient is buying drugs from a pharmacist or over the counter from the pharmacy and is continuing to abuse steroids. So that's when the problems with usage of steroids come. Or for example, if a doctor has prescribed steroids for some short period of time and patients tend to abuse the steroid and use it for a long period of time in a dose which is much higher than what is required for the therapeutic effect. So this is when the steroids tend to cause a lot of harm to the human body. So whenever I use steroids for a patient, I keep the 5 important things in my mind, 5 rights, what I call it as. So one right is right doctor, okay, then right patient. So right patient selection is very important, okay, then right dose, right duration, and for the right disease. So these are the 5 right things that I always remember whenever I am prescribing any form of steroid for a patient. So how does steroid work actually? As you all know, steroid has a immunosuppressive effect. So steroids don't work in a particular targeted way, they work broadly. So they target your innate immune system and they target your adaptive immune system both. Okay, for example, your other drugs like your biological, these are targeted drugs, they work against a particular pathway, but steroids are not like that. Steroids, they work in a very broad way to suppress your innate and the adaptive immune system in your body, and it will cause immunomodulatory and anti-inflammatory effects. So there are different forms of steroid preparations that are available. That is, your IV is available, IM is available, then tablets, which is an oral preparation, that is available, then intra-articular, that is also available. We use steroids into the joint also for any inflammatory conditions. For example, your inflammatory arthritis, your gout or a CPPD, for example, we do have indications to use steroid into the joint also. Okay, then there are topical preparations. Topical preparations are used for many skin conditions, like for example, SLE patient who is having a skin manifestation of SLE, or for a psoriatic arthritis patient who are having skin psoriasis. So these are common areas where we use topical preparation. Topical preparation is where we apply the steroids over the skin. Are all steroid preparations same? No, absolutely no. There are definitely 50 to 100 different synthetic steroids which are available, and each form of steroid has a different dosing, different potency, different efficacy. So it is very important for a rheumatologist to understand the efficacy, potency, safety, and the side effect profile of each different steroid, which is different from each other. And also another important thing to know is about the steroid conversion dosages. For example, your 5 mg of prednisolone is not equivalent to 5 mg of other steroid preparations. For example, a 5 mg of prednisolone is equivalent to 4 mg of methylprednisolone, which is equivalent to your 0.75 mg of dexamethasone, which is in turn equivalent to around 6 mg of deflazacort. So the steroid potency and the steroid conversion chart is very important to understand to select the right dosage for the right patient for the right indication. It is also important to know the steroid conversion dose for converting the, for example, from oral steroid you're converting to IV, okay, or from IV you're converting into oral steroid. Then you're converting from a shorter acting one to a long acting one, or from a long acting one to a short acting one, or you're converting it to a intra-articular or intramuscular route. So for all this, your steroid conversion and potency chart is very important. It is very important for a rheumatologist or any doctor, for example, to know at what dosages the steroids can be used. So for this, we have divided into 5 simple dosage categories in which we use steroids. One is your low dose steroids. Low dose steroid is any dose of steroid which is less than or equal to 7.5 mg per day of prednisolone or equivalent. That is your low dose steroids. Then we come to moderate dose steroids. Moderate dose steroid is anywhere between 7.5 mg to 30 mg per day. That is your moderate dose steroids. Then we come to high dose steroid. High dose steroid is between 30 mg to 100 mg per day of prednisolone or equivalent. This is your high dose steroid. Now, what is very high dose steroid? Very high dose steroid is any steroid dose which is more than 100 mg per day of prednisone or equivalent is called very high dose. Then we have pulse dose of steroid. Pulse dose is when we give very high doses in a dose of more than 250 mg per day prednisolone equivalent. More than this, it is called as the pulse dose. This we use for many organ threatening conditions or life threatening conditions like your SLE or your vasculitis, your lupus nephritis, which are, or your neuropsychiatric lupus, which can be a life threatening condition. So in these cases, we use pulse doses of steroids, which is equivalent to more than 250 mg per day of prednisolone. Okay, so what are the rheumatological indications where we use steroids? As I already told you, rheumatology is a vast spectrum of diseases that we treat from childhood till adulthood and till the time the patient dies. So we have a lot of indications in rheumatology to treat a patient with steroids. The common indications include, for example, your arthritis spectrum. As I already mentioned in my first video, rheumatoid arthritis, for example, is a common disease that we treat. So we do use steroids in rheumatoid arthritis. Then we use in connective tissue disorders like your SLE, your Sjogren's, your MCTD, which is mixed connective tissue disease. Then in inflammatory myositis also we use steroids. Then we have another spectrum of diseases where we use steroids, that is the vasculitis spectrum. It can be a small vessel, medium vessel, large vessel vasculitis. So here also we do use steroids. Then we can also use in sarcoidosis, IgG4 related disease. So do all rheumatologists treat all patients with steroids? No, it's a myth. Yes, we do use steroids, but for a limited duration of time and for the dosage which is appropriate to be used for that particular condition. Okay, so temporarily we do use steroids for a lot of conditions, but we do have something called second line agents, third line agents. Okay, so these are drugs which does the job of steroids as we slowly taper the steroids and stop over a period of time. So we have other wonderful drugs in the field of rheumatology called second line agents, third line agents, which does the work of steroids, but they work in a more targeted way rather than steroids which work in a very broad way. Okay, so for what are the drugs which we can use instead of steroids? So for example, we have something called CSDMARDs. Those are conventional synthetic disease modifying anti-rheumatic drugs. For example, your methotrexate, your sulfasalazine, your leflunomide. These are the second line drugs which we use so as to do the effect of steroids while we are tapering and stopping the steroids. Okay, then we have immunosuppressant drugs. For example, include your cyclosporin, MMF, that is your mycophenolate mofetil. Then we have CNIs, that is your calcineurin inhibitors. Okay, then we have azathioprine. So these are the immunosuppressive drugs which also does the effect of steroids but with a much lesser side effect and toxicity profile. Then we also have new era of drugs in rheumatology called as biologicals. So biologicals are highly specialized drugs which are developed with recombinant DNA technology, where they target a particular pathway that is responsible for the disease in that particular individual. So by using biologicals, your conventional synthetic DMARDs or your JAK inhibitors, we can get away with tapering and stopping the steroids, and this job will be done by other drugs which I already mentioned. So to overall summarize, are steroids useful? Yes, they are very much useful. Are steroids harmful? Yes, they are very much harmful. So the right patient, right doctor, right disease, right duration and right monitoring of the patient is required when we are using steroids. So we as rheumatologists are well trained to identify the necessary indications and the necessary dosing and the schedule of tapering and stopping the steroids for treating various autoimmune rheumatic conditions. So in my forthcoming video, I'll be telling you about what are the side effects of steroids, okay, and what are the monitoring that we must do when patient is on steroids. Okay, so I'll be discussing about this in the forthcoming video. So please like and subscribe to our channel.